Good evening. I'd like to talk to you today about intracavernosal injection therapy and how these medications work to achieve an erection. To achieve an erection, blood flow to the penis must be significantly increased. These medications work together to make this happen by influencing the blood vessels in two key ways. They either relax the blood vessel or block the contracting signal. Let's look at how each medication contributes to this effect. Aprostadil, prostaglandin E1, directly helps to relax the muscle and widen the arteries. Aprostadil kicks off a chain reaction inside the cell that produces a relaxing messenger, CAMP, which then tells the blood vessel muscle to loosen up and let the blood flow in for an erection. Papaverin helps to relax the smooth muscle by increasing essential relaxation messengers. By inhibiting the phosphodiesterase, PD enzyme, that break down relaxing messengers, CAMP and CGMP, papaverin allows them to accumulate, leading to relaxed blood vessels and better blood flow. Phentolamine specifically blocks signals that would narrow blood vessels. By blocking alpha-adrenergic receptors, it prevents the vessels from receiving signals to narrow. This allows them to relax and widen, which then directly increases blood flow. Atropine is a muscarinic acetylcholine receptor antagonist. This means it blocks acetylcholine from binding to these muscarinic receptors. So it doesn't directly cause a strong relaxation like some of the other drugs, but it rather removes an inhibitory or constricting influence, allowing the other relaxing mechanisms to work more effectively and for the blood vessels to dilate more fully. By combining these different and complementary actions, these medications collectively provide a powerful and effective way to enhance the ability to achieve and maintain an erection.
So let's talk about the different concentrations that are available from NMD. We have a number of different sets of options, ranging from Monomix, which is just pure alprostadil, all the way to Quadmix, which is a mixture of 4 different compounds, which we'll talk about in a second. So when the patients order these vials, they come in a 5 ml vial. And the thing the ones I most often prescribe are the Trimix, but we'll start with Monomix and work our way up. So Monomix, as I said, 25 microgram alprostadil alone, and this is equivalent to Edex or Caverject or some other sort of brand name option on the market that it's just pure alprostadil. Bimix, also very commonly used. Bimixes tend to be a combination of just papaverin and phentolamine. And in general for this, the concentration of the papaverin stays the same, although Bimix number 3 has a little bit of a lower amount of papaverin, whereas the phentolamine varies and it ranges from weakest to strongest. So we have all the way from Bimix number 3 to Bimix number 10. And papaverin tends to be, or was historically, the first drug that was discovered to help with this sort of process. So I'm sure we've all heard the history of the G.S. Brindley lecture. Brindley was a British physiologist who gave a talk at an AUA late afternoon erectile dysfunction session in, I think, 1983. And from what I understand, historically, this session was very lightly attended. There's probably a couple of dozen people in the room. It was late in the afternoon, so most people were preparing to go to dinner, the president's dinner with their spouses. So lots of people were there in, black tie, tuxedos, ballroom gowns, stuff like that. And Brindley gave a presentation discussing his discovery of papaverin, which he carried in a small syringe in a wooden box up to the podium. He was also wearing, from what I remember, brown sweatpants, and people were, scoffing at his presentation and saying, "Who is this guy? And he knows nothing about erectile dysfunction, blah, blah, blah." And then Brindley proceeds to say, no, I'll prove it to you. I have injected myself with papaverin, and look at my turgid erection, and then, lowered his sweatpants and walked to the audience, encouraging the audience to evaluate his rather rigid phallus. This was a legendary story, and many, many people around that age will claim that they were there at that lecture, but there really were very few people, and many of them are, of course, some of the stalwarts and the titans of male sexual health. Anyway, papaverin. So piperacillin was used almost exclusively for many years, and Brinley really used a lot of it. The problem with piperacillin, and the reason we don't vary it in the concentrations very much, is that it is the one that's most associated with penile fibrosis. So the concentrations tend to be the same across Bimix and Trimix formulations, as well as Quadmix formulations. So they're really pretty standardized across the board. And using piperacillin at higher concentrations than that, again, can cause problems. So we try to sort of minimize that as much as possible. The Trimix formulations you see here range from the weakest, which is number 14, to the strongest, which is number 16, which is rather counterintuitive. And that is not MenMD's fault. That is entirely the fault of the way and the order in which these were devised and created. So that's the numerical calculation, right? So the numbers of these trimixes are when they were discovered and starting to be used at Boston Medical Center back in the 1980s, 1990s, and 2000s. The most commonly used trimix that people start off with is mix number 5. Pardon me, my dryer is going crazy over here. There's a lot of noise. But trimix number 5, which is the standard, really much pretty much across the board for in-office testing, penile ultrasound testing, stuff like that. And then the strengths that go upwards from there are where you would move guys if they had not a good response. You'd move them up to other levels from there in the standard trimix category. The low range stuff is where you would put guys who had an episode of priapism during your in-office injection, and you wanted to start them off on something less likely to cause priapism. So your option in that circumstance is to dive all the way down to mix number 14, which is the lowest strength trimix that we have available, or even to go to Bimix and work your way up from there. The alprostadil tends to vary the most in these formulations. That's the one that we really it's doing the heavy lifting, basically, in the erectile dysfunction mechanism here. And so the alprostadil varies the most in trimix formulations. And the challenge with that, of course, is that alprostadil causes discomfort. It's an agonist for penile nerves. And so in patients, particularly with neuropathy, after diabetes for a long time, or after prostate cancer treatment, this can cause penile aching that is somewhat difficult to continue to use these medications. Quadmix is trimix plus atropine, and it comes in 2 formulations. Here, one is 100 microgram alprostadil, the other one is 200 microgram alprostadil. So how do these medications work? Well, Lianne described the really, really complicated physiological mechanisms of them, and to give them in more intuitive terms to give to patients, they just put blood in your penis, right? They just turn the faucet on and really pump blood into the penis at a rate that your penis can no longer do, which is why you're using these medications. This is different from the mechanism of PDE5 inhibitors, which tend to break down the mechanism that breaks down erections and allows you to sort of maintain the erection longer and have greater durability and more efficacy. These work very well to get blood into the penis and help keep an erection strong enough for the entirety of sexual activity. The injection medications we talked about, and we talked about the different formulations of them. But the best way to explain this to patients, pardon me, is to describe it like a faucet, right? And everyone's got a faucet in their office. So basically what you do is you lean over to that faucet, you turn the hot or the cold all the way up, and you say, this is exactly what these medications do to your penis. So starting dose and titration. Generally, I tend to set the first dose for patients at 20 units. And of course, when I'm describing this to patients, I really try to clarify for them the difference between the strength, which is something I control, and the dose, which is something I give them control of, right? They can alter the dose to their needs. The way I generally describe it to patients is that the dose changes the duration of the erection, and the strength changes the rigidity and the quality of the erection. So in the office, my protocol is a little bit different, again, because I was trained at Boston Medical Center by Dr. Menares, and so we do a lot of penile ultrasounds. And this is not a necessary step in a intracavernosal injection practice at all. This is just something that I was trained to do, and I feel comfortable doing, and I'm happy to do. And by the way, if you want to learn how to do it, I'm happy to have you to visit me up at Dartmouth. I'm sure Dr. Menares also likes to have people visit him in Boston as well. We are very strong proponents of this method. But that said, you bring the patient in the office, ultrasound or not, right? Typically, what I'm aiming for when I start this is I have the patient placed in any kind of room, right, any exam room, and I'll have the staff check their blood pressure and heart rate, right? Because if I have to give them phenylephrine to counteract this erection, I have to make sure that their blood pressure is within safe parameters before we get started. If the guy's got a diastolic blood pressure of 120 and a systolic of 160, I'm probably going to cancel for that day and have him go see his PCP and see what's going on. Because if I have to give him a rescue dose of phenylephrine, well, that's going to crank up his blood pressure and reflexively lower his heart rate, which is not ideal. So I want to make sure that I have a safety margin to work with as soon as the patient gets in the room. Then, as long as there's nothing weird, which the staff reports to me, we go ahead and proceed. And I will walk in the room and I will dose the patient generally with about 20 units, 0.2 milliliters of mix number 5, which is the 10 microgram alprostol Trimix. What I'm aiming for in this circumstance is an erection that comes down in a reasonable amount of time. What I tell patients is these drugs will generally give you within 15 or 20 minutes, an erection lasts anywhere from a half an hour to 2 or 3 hours. The dose, again, is dependent on the dose. The duration is dependent on the dose. The rigidity is dependent on the strength. And of course, what I'm aiming away from is an erection that doesn't go away, right? Unfortunately, in your first initial office visit, this is always a potential risk. And so you really have to counsel patients. The main risk of the in-office teaching we're going to do is that you might have an erection that won't go away. I have to give you other drugs to make that go away. Those drugs are pretty unpleasant, but they work, well to make the erection go away in a rapid period of time. So again, what I'm aiming for is an erection that is not too durable for too long, and is substantial and suitable for penetration. And that means the entirety of penetrative intercourse, right? Whatever they and their partner are comfortable with. Many studies show that the average American is comfortable having sex for about 12 minutes. And so I'm aiming for a half an hour to 45 minutes for most of these guys, just to give them an erection they can use for foreplay as well as penetrative sex. Important things I tell the patients very clearly when I'm counseling them, after this process is do not exceed the maximum prescribed dose that I give you. And so usually I give them a range of I'll start them off at 20 units and I'll say increase or decrease as needed in 2 to 5 unit increments with a maximum dose of 40 units. I also advise them that they can't really inject more than every other day. So typically for most guys, it's about 4 days a week. They can use PDE5 inhibitors in between those doses. So for example, if they inject on Tuesday and they want to have sex again on Wednesday, they can use, Viagra, Levitra, or Cialis. But of course, they're here because they don't respond to that stuff very well. So it's not going to be a great, awesome erection in that circumstance. But then on Thursday, they can go back to using intracavernosal injection. And the point of this minimization of dosing frequency is to make sure that you're not, you really want to reduce the likelihood of fibrosis and scarring and stuff like that. So, use medication sparingly. But again, many of these patients have had erectile dysfunction for many, many years. Having sex once or twice a week is a remarkable upgrade from their current sex life, which has been defunct for the last 10 or 15 years or so. So once or twice a week is pretty common. It depends on the guy. Anyway, back to my injection protocol in the office. So I give them a dose. I generally will leave the room for about 15, 20 minutes. And then I'll come back and I will evaluate the erection myself manually. Just put some gloves on and say, this looks like it's about a 5 or a 6 out of 10 or something like that. And I'll also ask the patient what he feels the erection is, which is important because you really want to gauge what their perception of this is, right? Because that helps you evaluate their perception of this whole process and their understanding of it. So if you say that this is like a 2 out of 10 and the guy says it's like an 8, that's a big discrepancy there. And you really want to talk to the guy and say, you sure about that? Because a 6 is about the rigidity you need for penetration. Whereas, a 2 is just sort of it's a chubby. It's not really, it's not a very useful erection. As Dr. Bullock says, it's a stuffer, not a poker. Anywho, once that's done, I will typically perform a penile ultrasound. Again, not a vitally necessary step. What you can do from there, depending on the results you get in the office. With the ultrasound, you have the advantage of seeing exactly why it is or is not working, and you get a sense of the parameters you can use to kind of upgrade the strength from there. Without that, you can still, do a trial and error process and send the guy home with something stronger. Usually a prescription for, let's say, for example, if the erection is suboptimal, let's say a 5 or a 4 out of 10, not quite good enough for penetration, you can double the strength to mix number 8, which is 20 microgram alprazolyl trimix, and potentially get decent results. If I'm sending a guy home with that protocol in mind, what I will tell him is take this pamphlet home from NMD, which is it's a very nice double-fold pamphlet that has this rigidity scale and this progress log on the back. And so I will say, look, today we were here, and I'll put a star above what his rigidity was today. Let's say it's a 3 out of 10, hypothetically. And I want you to be in this nice red zone over here, the goal range, which is an erection that's a 7 or 9 out of 10, somewhere in that range. And 80% erection is good enough for penetration. I will also say to this guy, hey, let's log your progress on this sheet so when you come back and see me in a month with an update on this, we know exactly how it went. So I'll put myself in this log that you see here. I'll put the volume injected, which is going to be 0.2 every time at home. Right? I don't want them really fudging with it for the first couple of shots here. And then I'll have them write down the date of use. They fill in that information, the duration of the erection, and the rigidity scale based on this 1 to 10 scale we see here, or 0 to 10 scale we see here.
Test dose protocol.
Take it
So
away, Lianne.
how can we test in the office before we give the patient their file that they're going to have to purchase? So we do have some test doses that once you contact MenMD, they can go over and tell you how to order those. But we have all 3 available mixes as Monomix, Bimix, two strengths of Bimix, which is number 4 and number 10, which is just the papaverine and the phentolamine. And then the Trimix, we have 4 strengths, the Trimix 5, 8 that Dr. Gross has been speaking of. And then we also have a 9 and a 13 that are a little more, have a little more strength to those. And you will get 50 units in a test dose. So as Dr. Gross explained, he usually starts out with 20. So you have enough in there to do 1 test dose for the patient. And then if you choose to give maybe another 10 units or 2 to 5, however you decide your protocol is going to be, you have enough to maybe give a little bit more, want to do more than 20. And then how do you choose a formula? Do you just always start off with Trimix 5, doctor?
I do for the most part, unless a guy comes in and he's already failed Trimix number 5, in which case I'll bump him up to 9 or 13 or go from there. But in general, and again, looking at the literature, this is pretty much the consensus across the board that 10 microgram alprazolyl trimix is the standard you start guys at, and you work your way up or down from there. And more specifically, from my perspective, this is what I learned in residency and what I'm most comfortable with. But again, if you're looking at the literature on this, it really is the conventional wisdom for everybody who's doing a lot of intracavernosal injection in the office. So the good thing about Trimix number 5 is it gives you a lot of options above and below that strength to work with. And so you can kind of over time create an algorithm in your head of which way you want to steer a guy as far as the next shot. So if number 5 is not effective, for example, in the office, generally my pathway is to go to number 8, which is 20 micrograms, and then potentially go to number 9, which, wow, that's really loud. I'm sorry. To number 9, which is 40 micrograms, and then number 13, which is 60 micrograms. And then beyond that point, patients are on their own as far as, these other doses of mix number 16 or extra strength Quadmix. Those are mixtures that don't come as test doses, right? Because these are very uncommonly prescribed things. But in general, my pathway for management is, let's say a guy's in the office, he doesn't get a great erection with 5. I say, let's try number 8 at home, see how it goes. And then he comes in at number 8 and he says, yeah, that's not really working. Well, then let's try number 9 and see how it goes, which is now 4 times as strong as what you got in the office. From there, if a guy fails number 9, I try to assess what kind of gambler he is, if that makes sense. So what I tell the guy is, look, number 9 didn't work. I got 2 options for you. One is to increase the strength of this medication to mix number 13, which is a 50% increase in the strength roughly, right? So we're going to go from 40 microgram alprazolyl trimix to 60 microgram alprazolyl trimix. That is not a huge jump. And if if it hasn't been trending the right direction thus far, I'm not convinced that's going to work for you. But it is safer to try because the risk of priapism and the risk of penile pain are both substantially lower. Or I'll offer him door number 2, which is mix number 16. And in that circumstance, what I'll say is, look, in this case, what we're doing is more than doubling your strength of Trimix, right? We're going to mix number 16, 100 microgram alprazolam Trimix. This is a big boy medication here, but we get to an answer faster, right? If this doesn't work for you, then we'll know that because you've tried basically the strongest Trimix I got. You're not getting a response that we want. Or we can take it easy and try mix number 13, which is a little bit of an easier jump. Many of my guys don't like to gamble. I have a very conservative population up here, and they really are not interested in gambling. But some guys want to gamble and push all their chips on the table and go with number 16. And they often get a really good response that they're very happy with, as opposed to the guys who do 13 and then eventually come back and say, let me go up to 16 because that wasn't fantastic. But again, with a big jump from number 9 to number 16, there are increased risks of penile pain and priapism. The penile pain is more likely. The priapism probably hasn't happened until that point, and so it's unlikely to happen moving forward. But again, you have to counsel guys that those are the 2 potential risks in that circumstance. So again, the 2 things highlighted in light blue here are medications that are not as test doses, but this is my general pathway for this process. And so the rest of that pathway is, let's say I got a guy who's been on 16 for a number of years, and he finds the medication is waning in efficacy over time. Then I say, well, luckily for you, MenMD in the last few years has pioneered a new formulation of Quadmix for them that has been great. And so Quadmix extra strength is essentially double the strength of Trimix number 16 plus atropine, right? So you're basically getting 200 microgram alprazolam Trimix. I can also offer them, Quadmix standard strength, which is just the same thing as Trimix number 16 plus atropine. But quite honestly, what I try to do is say, this is going to be more effective for you. Let's bump it up to Quadmix extra strength and see how we go from there. If patients have come into the office and have previously failed Trimix in the past for their test dose visit, what I'll do is I'll request a test dose that is at least 1 strength higher. And the other thing you're assessing during this process, besides rigidity and besides quality and duration, et cetera, is pain, right? And this is not particularly common. I don't encounter a lot of guys who have pain. They tend to be, for the most part, again, severe diabetics with bad neuropathy or post-prostatectomy patients. But when that occurs, again, alprazolam is the prime driver of pain in this equation. So if you remove alprazolam from the equation and you just start them on Bimix, you get a much better potential reaction without you get hopefully a similar erection quality without the pain quotient involved in that process. Again, I usually perform this with the penile duplex Doppler ultrasound. What the advantage of that I find are twofold. It expedites the process, so there's less trial and error. So you can really show a guy, and again, this is a kind of pull back the curtain thing here, but you can really show a guy on this ultrasound monitor. You can say, look, this is what your flows look like. Your peak systolic velocity is not particularly great. Your end diastolic velocity is half that or more, right? So you have a really poor ratio of blood in to blood out of your penis, and you're not able to maintain erection you want even with injections. And so this may be something that we move on from and we get closer to a penile implant. But I love doing penile implants. I'm not here to talk about that today. I'm here to talk about MenMD. So realistically, you don't have to do this with ultrasound if you want. You can still get a good sense of the guy's response and other stuff in the office. It also helps to clearly identify a priapism when you do an ultrasound, right? So if obviously you don't need an ultrasound for that either. You can just look at the guy's penis and it's not going anywhere. But if you have an ultrasound, you can really see an arterial clamping that occurs that is very obvious. There's very little flow in those arteries. And there is a pretty substantial, tendency towards a prolonged erection at that point. If that occurs, I will generally leave the room for about 15, 20 minutes and give the guy some time to cool off and let his veins open up. And then hopefully the priapism starts to resolve. And then I have more confidence I can send that guy home. But if there's evidence that this priapism is not going anywhere, I'm busting out the phenylephrine and getting to work. The last thing about ultrasound that's very helpful is it helps establish rapport with the patient. Again, a lot of my patients their health literacy is not great, if that makes sense. And so what I'm trying to do is show them visually and demonstrate for them, both with their penis and also with what I'm showing them with the test results, that this is a thing that is going to work great for them or not going to work for them at all. So it gives you a sense of, look, I'm not just talking, my diploma doesn't come from the back of a Cracker Jack box. It's legitimate. And I'm showing you data that shows that this works or doesn't work. But enough about penile ultrasound. The disadvantage, of course, is it costs more to the patient, right? An in-office injection visit is just going to be a 54235 code without the 93980, which is the code for in-office ultrasound. So there is less cost. You don't have to do any prior authorization to see if their insurance will cover penile ultrasound. And again, it requires a degree of expertise, but that's a degree of expertise that I'm happy to teach you if you want to come up to the frozen tundra up here and learn how to do that. Again, I have patients keep a dose log with their MenMD pamphlet I send them home with, and usually I follow up 4 to 6 weeks later and then titrate from there. That 4 to 6 weeks, honestly, I tend to err towards the 6-week option because it gives guys time to get the medication, right? The shipping process and stuff like that, and get contact. MenMD calls these guys often before they've left my office. So I'll put the prescription in on the website, and the guy will be sitting there talking to me, and he'll get a phone call because the conversations run a little bit long. And I'll be like, oh, they're calling me from Boston. I go, oh, well, then plug that number into your phone, and that's the number they're going to call you back at. You call them back at. You start this whole process up and go from there. But generally, customer service reaches out to them within at least 2 days or so. And then the shipping tends to happen usually on Tuesdays. If I'm correct, Lianne, please correct me if I'm wrong.
For the test dose.
Yeah, for the test doses. But their prescriptions go out all week long then, basically. And so they get the medication, but then, they have to find time to try it. It's not quite great. They have their grandchildren are visiting, or, their partner lives in Saskatchewan. They have to fly out to visit them, stuff like that. So, 6 weeks gives you more leeway to kind of say, all right, come back in 6 weeks and tell me how it's really going. Bring this pamphlet, come back and go from there. And then monitor the reaction. So, assessing their response with the patient, asking them what it looks like to them. With the partner also, if the partner comes to this visit, it's super helpful. You really get a sense of their partner's involvement. Many of my patients can't see their penis particularly well, and the partner's very capable of learning how to inject them and to facilitate this process. And of course, assessing the response with the ultrasound as well. Not a necessary requirement, but very helpful. You should have a phenylephrine protocol in place in case priapism occurs. I tend to have my staff keep about 4 or 5 vials of it in stock in the office. And this stuff expires, once every 6 months or so. So it comes in a little brown a plastic bag, so it's not exposed to light. So I go and look at it periodically, and I look at the dates, and if it says, February 2025, I'm throwing that out, and I'm calling the pharmacy and saying, can you send up more phenylephrine and have it available? As far as phenylephrine injection in the office, again, I was trained in a very rigorous fashion with this whole process, so I tend to pull it directly from the bottle and inject it in the patient's penis. I don't advise that if you don't feel comfortable doing that. If that's not a thing for you, don't worry about it. Follow the AUA priapism guidelines, which give you a very clear dilution that makes sense, and dilute the phenylephrine to the appropriate dosing. But make sure you get it in the penis quickly, and obviously you assess for a few minutes and see what's going on. But then if that's not working, get another dose in there quickly as well, right? So go right side and then left side, 5 minutes later, then right side. I put the patients on a monitor usually, and I have the nurse sit with them to monitor their heart rate and blood pressure. And I warn them, if you have a priapism and I have to give you phenylephrine, it does not feel good because your blood pressure shoots up and your heart rate reflexively drops down, and you feel like crap for about 15 minutes or so. You lay back in the bed, you don't move, you don't get up, you don't walk around. You'll notice that as soon as the medication kicks in, the guy, feels, I don't really feel great. And you'll see, of course, on the dash monitor, the blood pressure will go and the heart will go. And so you have to kind of say, okay, we're done with injections. I'll assess your penis. Looks like you can bend it back on itself. That's perfectly fine at this point. You have the nurse continue to monitor the heart rate and blood pressure. And then you come back and check periodically, make sure things have resolved. If they've resolved sufficiently, you send the guy home once his blood pressure and heart rate have resolved to normal, and you document in the note what you did, and what the blood pressure and heart rate were. You have the nurse write that down and put it in the chart. And then you say patient left the hospital comfortable and functional and with normal parameters for heart rate and blood pressure with no evidence of priapism in that circumstance. If a priapism occurs with the dose of number 5 I give them in the office, I will generally drop them down to the lowest strength Trimix, which is number 14, and then work my way up from there carefully. If, on the other hand, the Trimix also results in priapism, then I'll drop them down to the lowest strength Bimix and work my way up from there. This is an important thing to recognize, that sometimes you will have, rarely, probably once every 6 months, maybe once a year, depending on your volume of how often you do intracavernosal injection, you'll have a paradoxical response guy. Paradoxical response guy gets a priapism at number 5, gets a priapism at number 14, and gets a priapism at the lowest strength Bimix. This is a challenge, because they'll want to keep going with this, and you just have to tell this guy, look, you have this super physiologic paradoxical response. Don't use those words; they don't make any sense to patients. But you have a bad response to this medication that is going to generate an erection you don't really want, and we got to move on and do something else. This just isn't going to work for you. But it is reasonable to at least go down to the lowest strength of either Trimix or Bimix, and then work your way up from there carefully and cautiously. If a guy's going to go home, for example, with a prescription number 14, I'm going to tell that guy, listen, I'm in the office every Friday. I'm not in the OR. I'm just sitting around the office seeing patients. If you're going to inject this Trimix strength and you had a priapism already, inject that morning. Wake up at 6 a.m. Inject yourself. You try and have sex with your partner before they leave and go to work. And at noon, if it's still hard, come and see me, and I'll inject you in the office, right? Just to make sure that I have built off some time for them to come in for priapism. It's not in the middle of a busy clinic morning or a busy clinic afternoon, but it is a structured way to say, come back to me, I will take care of this for you, as opposed to sending them to the ER where you're going to get haphazard following of the AUA priapism guidelines at best. Writing for test doses, I obviously say, inject intracavernosally as directed in the office. What I typically will put in my prescription that's very specific is it's word for word. In fact, it's so commonly written on my Microsoft Edge browser that it pre-fills it for me, which is great. What I write is inject 20 units. Of course, I have to explain to patients the difference between units and tenths of a milliliter. But inject 20 units. Many diabetics are familiar with that. Increase or decrease as needed in 2 to 5 unit increments, while also having explained to the patient that the increase in dosage changes the duration, not necessarily the erection rigidity. The next thing I say is maximum dose 40 units. Beyond that point, it's no longer really cost effective for the patient, right? So if a guy's injecting almost half a syringe of medication into his penis, that's a lot of volume, first of all. And beyond that point, it's really not ideal. So I say, if it's not working at 40 units, come back and we'll move up to a different strength, right? We'll try something else. And the last thing I say in my prescription is seek emergency attention for a rigid erection lasting longer than 4 hours. MenMD also tells them this, but I'm documenting that in my prescription that says, listen, I told you this on paper and in person and from the pharmacy. Don't screw this up. If the erection, first, yes, have sex, take a shower, put some ice on it, but don't, if it's not going away at 4 hours, this is not something you play with. This is a legitimate problem that can cause significant damage to your penis. Don't screw around. Go to the ER. Unless I'm in the office, in which case come to see me. I tend to order through the portal, which is super helpful. Some people also can use it through, or they can write new prescriptions through their EMR. But the test doses go through the portal, and they recently pioneered a new method of doing that, which is actually quite convenient and not onerous at all. The orders ship on Tuesdays, so you really want to do it at least a week prior. I tend to look at my penile ultrasound calendar for weeks in advance and say, oh, I got 2 days this month. I need to get, uh, 15, 16 doses lined up and kind of go from there. And the beyond use date for test dose is an average of 90 days. So you have a long window to keep these in the office to use them potentially down the road. I hope I'm not talking out of school, right? That's you guys are okay with that.
Right on the money.
Perfect. Awesome. The other thing I do before a guy leaves the office is, again, I reiterate how this injection happens, right? So as part of my injection protocol, I know we've already started off by saying we've checked his blood pressure. I've explained to the guy there's a risk of priapism one more time. I tell him to, before we do the injection, and then I do the injection process with him by hand, right? So I say, look, you take this 10 cc syringe, 1 ml syringe, excuse me, you uncap it, you open up your test dose and flip it upside down. You take the little metal tin off of that so you can get to the rubber stopper. You inject this in the bottom of that. You draw up to 0.2, and I bring that very close. I say 0.2, not much medication. Look at it right there, sir. They go, yes, I've got it. Then I cap the needle off for my own safety because I don't want to actually inject myself, which I did many years ago at the VA with a dose of Edex, which was quite traumatizing emotionally. And my finger was like this all day. It was terrible. And then from there, you bring the alcohol swab and the syringe to the patient, and I usually have them in the gown, so I lift up the gown. I look at their penis. I bring the wife or husband or spouse or whatever over, and I say, okay, so you're gonna take the penis and you're gonna put it on stretch, right? You're gonna clean off the side you want to inject. In this case, I'm injecting your right side, but you wouldn't do the right side every time. You do the right side one time, the left side the next time, then the right side, then the left side, right? Not in the same session. Thursday, Saturday, Monday, etc. And then you clean off the side you're going to inject. You really want to be careful to avoid any obvious skin blood vessels. So you can kind of steer the skin around so you avoid any big blue veins in there. And then I tell the guys it's either 10 o'clock or 2 o'clock within the first inch of the penis. So 10 o'clock or 2 o'clock within the first inch of the penis. Some people go more down mid shaft. It's just not the way I was raised. I'm perfectly happy to do, the first inch of the penis, but mid shaft may be easier for guys who have poor visualization of their penis due to body habitus. And so then, I show them. I say, look, the needle's all the way in there. You push the plunger all the way down. You take it out. You cap it off for safety. And if you take anticoagulation, or even if you don't, you hold a little pressure on there for about a minute or so. And while you're there, it doesn't hurt to just jiggle it a little bit to get the blood flowing in the right direction, but really holding pressure, particularly for guys on Eliquis, Xarelto, Coumadin, aspirin, Plavix, whatever. You really want to get a little bit of pressure on there. They are more prone to form a hematoma if there's not a little bit of pressure afterwards. All right. And then, so by the end of the day, when I get home, I have taken my pen and I have drawn, a dot at 10 o'clock or 2 o'clock on my finger all day long, just pop here, pop there. So I'm showing guys where this goes in the penis. So I get home, my wife looks at my fingers and she goes, oh, it was DDU day today. I say, yep, exactly right, because I have my 10 and my 2 within the first inch of the penis. One knuckle out is what I say, right? One knuckle's length down the shaft of your penis. Okay, so supplies and preparation. Supplies you need in the office. I tend to keep these very nice BD Safety Glide 27 gauge half-inch needles in the office. They are super easy, super helpful. I tend to use these in the office because it's also my hospital has in stock quite a bit of. So, I'm not asking them to get stuff they don't usually carry. At home, for home use, I tend to prescribe, of the many, many options that MenMD offers, I tend to prescribe 29 gauge, either 5/16 inch or half-inch needles, which I find are durable and work best. As far as the dose available, you can either use a 50 unit or 100 unit syringe. It doesn't really make a difference. I tend to use 100 unit syringes just because it's easier to hold in their hand. Narrower gauges, like a 31 gauge needle, for example, can be prone to bending, and there is anecdotal and even papers written about this, that it can break in the penis and you have to go in there and fish it out. So I tend to like 29s. They're still sturdy. They're not too big. They're not too small. They're pretty comfortable. Patients often ask, is this going to hurt? And I refer them to a very nice study done at Mayo Clinic Jacksonville by Dr. Broderick, where he gave guys a survey before and after ICI injection. So the survey was report your anticipated pain scale on a scale of 1 to 10, which they reported as 6 before the injection. And then after the study, gave them another pain scale and said, report your actually experienced pain. And they reported 1.2. That's a 5-fold difference, right? Guys anticipate 6 out of 10 pain and have 1.2 out of 10 pain. This is really, it's like a little poke. It's a little poke in the pecker. It's not so bad. And if it gives you an erection, who cares how big that needle is? It works perfectly fine. You're going to want to use it. Auto injectors can be used. Many patients like auto injectors. They help to hide the needle for needle averse patients. The only challenge I encounter with auto injectors is that patients have to not only load the needle up, right? So they draw the medication up, but they have to stick this in the auto injector, which they may not be technically feasibly able to do so successfully. It depends on the guy. Some guys are very facile and comfortable with them. Some guys can't figure them out, but certainly are helpful for guys who don't love needles, which is the occasional intracavernosal injection patient. The test doses you order from NMD do not include syringes. You have to have your own supply of syringes. And again, I really like this BD Safety Glide 27 gauge half-inch. Works great. I have a barrel of them in my procedure room. I just scoop one out, and then we do the whole process from there. Swab the injection site with an alcohol pad, allow it to dry. This helps prevent infection. Inject at either the 10 o'clock or 2 o'clock position, obviously away from veins, and apply compression as we talked about. Patient preparation. Injection teaching needs reinforcement. This is the big challenge of intracavernosal injection in your practice. It needs reinforcement. When guys come in, you have to reiterate the same stuff over and over again. Injection dropout rates are not insignificant. And part of that is that patients don't get proper teaching and don't get proper reinforcement, right? So when a guy comes back in his 6-week visit, he says, it worked great about half the time, but half the time it doesn't work at all. There's something wrong with this drug. I say, that's not the drug. That is a user-dependent thing. I expect guys to fail about 50% of the time for their first 10 injections because they're not used to this. This is not a thing they do, right? This is a very foreign concept. They're having to surmount these hurdles of fear of injections and needles, and it's just not a thing they're comfortable with. If their spouse or they are a nurse or in the medical field, it goes much easier, and those guys have 10 out of 10 success every time. But for the average guy who's never seen a needle in his life, or since he's had vaccinations in preschool, this is very difficult. So you at every visit, again, I 10 o'clock, 2 o'clock within the first inch of the penis, right? And it really helps to involve partners, right? For these visits, particularly for the primary injection teaching, but also for the fall visits, involving the partners just makes sense. Lots of my guys can't see their penis. And you say, well, stand in the mirror and look at it. That's great, but their penis hangs over their penis in the mirror. I know this from personal experience. It's very challenging, right? It doesn't work. Anyway, so the moral of the story is really involve their partners. You get 4 hands in this process better than 2 hands. We had a very wonderful list of 9 questions sent in by people. All right, my question's over here, so I'm going to look back and forth between this monitor and that monitor. What are the drugs that are used for ICI dosing and the suggested dose? We covered that pretty well in this seminar, but just to be clear, start with number 5 and then work your way up or down depending on the response in the office. The suggested dose is going to be 20 units every time, right? So that's why I'm going to give the guy 20 units, and at home I want him to start at 20 units and then adjust as he sees fit from there. For example, you'll have a guy who, they like to go out to dinner after they have sex, and so he has a 3-hour erection, and I say perhaps scale it back from 10 or from 20 units and go down to 5 and work your way up from there. At 5 units, he has a 45-minute erection. That works perfectly fine. He and his wife can go out to dinner. But at 20 units, he's, awkwardly not going to dinner for about 3 hours. Question number 2, the vials are a big patient expense. I hear you, but one point about this, NMD has really, really good pricing. Part of the reason, I love this company is because the pricing is comparably excellent to other compound pharmacies and is very good, and there is an extraordinary degree of customer service that comes along with that pricing. So Moving on from there, the rest of the question, what instructions do you give regarding freezing and refrigerating vials? It's a very good question. I think the most important thing with refrigeration is a lot of the local compound pharmacies around me mandate that the patients freeze the medication, which is rather inconvenient to have sex later on, right? So, for example, if the guy freezes the medication, comes from some compound pharmacy in upstate New Hampshire. It's like when you take a pork loin out of the fridge, you got to eat it the next day. You know what I mean? Like it's going to be it's got to go in the sink to defrost for a little bit, or in the fridge to defrost for a little bit, and eventually you take it out and go from there. It's a lot of extra step I don't particularly love. But you have guys that don't go through a full bottle in a 2 or 3 month period, and they just don't use it that often. So refrigeration, I think, is pretty good. I'm going to give you a little bit of off the record. MenMD doesn't hear this kind of stuff, and that is this. When I talk to guys at their follow-up visit, what I say is, look, the beyond use date on your vial is going to say 28 days, discard within 28 days. There is good reason for that. The pharmacists do not know you personally. They don't know that you are a guy who will clearly wipe off the top with an alcohol swab of his ball every time he uses it, and then will refrigerate it properly and not leave it on the countertop for 2 or 3 months in a row. So if you treat the drug properly, you refrigerate it and you wipe it off an alcohol swab before you use it, you can probably get about 2 or 3 months out of that dose. If you find you're not having success and the dose has been in the fridge for a while, perhaps it would be prudent to order a new vial. But again, you can probably get 60 to 90 days out of it. But that is not from MenMD. That is from me personally. That is my opinion only. Do as you see fit and what's appropriate for the patient. What concentration and dosing protocol do you recommend for post-robotic prostatectomy patients? This is a loaded question. If the question is for penile rehab, I will emphasize that the literature is there's no, let me phrase this delicately here and diplomatically. There is no convincing literature that penile rehabilitation works for post-prostatectomy patients, period. There is literature. It is not convincing. It is not clear. It is not clear-cut, etc. So if you're implementing an injection protocol to try and restore native erectile function in a rehab fashion, I am dubious that will be successful for the patient. Part 2 of this question is, what would you give a guy who just comes in and he wants to use injections and go from there? Also a bit of a loaded question. Here's my opinion. Again, my personal opinion. I often find that injections do not work particularly well for patients who've had prostate cancer treatment, whether it's radiation or surgery. Those guys, along with Peyronie's patients, tend to develop venous leakage erectile dysfunction, a function of the neuropathy, for example, or the issues with the nerves after surgery, or the nerve sparing or non-nerve sparing, whatever else. But they tend to get venous leak, whether it's radiation or surgery. And venous leak ED does not respond great to intracavernosal injection, because venous leak does not keep the blood in the penis, right? So you can pump as much blood in as you want, but you're never going to get to that pristine, awesome 10-to-1 ratio of blood in to blood out that you need to get and maintain a really good erection. Usually 30 centimeters per second peak systolic and less than 3 end diastolic. You're not going to get to that ratio when a guy's got venous leak. So I'll walk them through the protocol and I'll say, look, if you really want to do injections, I'm happy to do this. I'll start with number 5 and work our way up from there and see how they do. I don't often find they have great success. I sometimes find they have a paradoxical response I don't like, or they have neuropathic pain because of the prostadil. And the caveat to all this is I often find that those prostate cancer treatment patients are the most reticent to pursue an implant, which I think that they need, and the most interested in pursuing injections, which is difficult. The logic I've come up with this over the years that makes sense is that my impression is that these guys, the last surgery they had was devastating to their penile health. And the prospect of another surgery to restore that health does not appeal to them very much. So they are eager to try injections to see if that works. And sometimes with a population that is the least likely to find an efficacious response in that circumstance. That said, you walk through the process same as everybody else. It doesn't work, it doesn't work. The good thing about the penile ultrasound is you can look at it and say, and here's why it's not working. Look at this monitor. It says, your peak systolic is fine, your end diastolic is half that. that is not a ratio that's 10 to 1. It's a 2 to 1 ratio. I can't get you to 10 to 1 ratio with this. We might want to move on. But again, when do you choose Bimix versus Trimix in concentration? I tend to stick with Trimix most of the time. I tend to use Bimix in circumstances where I want to really scale it back because there's been concern for priapism. I'm not a huge Bimix user. There are many people in New England who use a ton of Bimix. They are more comfortable with that. They find that the pain is less. So I would put a guy on Bimix when he's had evidence of alprostol related penile pain, for sure, no question. I will put him on if he's had evidence of priapism, sure, no question. But I don't really start with that. I tend to start with big guns that I'm pretty confident are going to work, and that tends to be Trimix. And from there, I move up. For the most part, for the vast majority of patients, I move down sparingly. The best options for men with priapism using low test dosing with Trimix number 9. This is an interesting question. I'm not really sure what the question is actually asking, but I suspect what the question is asking is if I'm injecting 9 in the office, what dose should I give them? I'm going to tell you a story. Early on in my career, there was a period in time when all that was available was mix number 9 for one of the days that I was doing penile ultrasounds in the office. So I only had 9 to work with. That partly was my fault. It was an ordering issue, and that has since been completely resolved, never happened again. But I only had number 9, and so I went with the day saying, all right, I'm not great at math, so I don't really know what concentration to reduce this to. Let me just try it at like 5 units with every guy, which is, it seems like a quarter strength, which is, 9 and 5 are 4 times different from each other. So they give them a quarter of the usual dose. They give them 5 units instead of 20 units. Maybe this will go well. I had 2 priapisms that day of the 8 guys I injected, and they were really prolonged priapisms. So my response to that question is, I would stick with number 5 as a starting dose for everybody, unless there's evidence that they've previously failed other medications and go from there. MenMD happily packages and ships out a lot of number 5 test doses. It is the standard across the board. Stick with that. I wouldn't try to adjust to a lower dose, but non-standard strength like number 9. It's really not a, I didn't enjoy that day. I didn't enjoy fixing 2 priapisms that day. It was a lot of stress. Put me like this closer to a heart attack. So I'm not thrilled with that idea. When needing to increase the concentration of the ICI, is your preference to increase the concentration or change from Trimix to Quadmix? Again, I'm really going to jump to Quadmix only in the circumstance where I've run out of strength in my Trimix mixes. I have a lot of confidence in mixes 5 through 16, 5, 8, 9, 13, and 16. I'm going to just go up that ladder until I run out of room. And when I run out of room, I'm going to go to Quadmix extra strength, which is now twice as strong as mix number 16 with some atropine on the end. Other rationales for using the lower strength trimixes besides the risk of priapism is, again, when you decrease the dose of alprostol, you decrease the penile pain quotient. So a lot of those trimixes, 14, 7, et cetera, were invented at BMC back in the day at Boston University to give options for guys who are complaining of penile pain with this stuff. So you have a lot of flexibility. The reason I have such confidence in the system is because there's 16 different options here. I mean, you have a ton of options to work with here. So, you can really work your way down or up based on priapism and or pain as the response, and of course rigidity as the parameters you're trying to gauge here. Can patients become immune, in quotes, to Trimix and therefore need to increase their dose over time? Absolutely. This is a known quantity with Trimix. When I counsel a guy about intracavernosal injection, what I'm usually telling him is that you will get probably on average a 4 to 5 year response with this medication. And in that time frame, we will have to increase the strength as time goes by. And at some point, we may run out of strength. But this is like all medications, the efficacy of this wears out over time. It's still an awesome magic trick. I mean, when it works the first time, it works great. You're really happy with it. But over time, it loses efficacy. And that is the fibrosis that develops in part, but it's also the progression of the ED. This is not solving the ED problem for the patient. It's simply giving them a lot of blood push in their penis, which doesn't solve the problem. It just fixes it temporarily. And as time goes by, the ED worsens. The deposition of, fibrin and collagen and sort of, things and the cause fibrosis in the penis progresses. And so things don't work as well. It's no big deal. I mean, for example, if you have a guy who's coming in at 74 years old and wants to start Trimix and you tell me you get 5 years out of that, that's the last 5 years of his life on average, right? So that's a pretty good odds that he's going to have a lot of sex with your handiwork in that time frame. If he's 42, it's a little bit different. But anyway, how do you quickly establish a Doppler clinic at a satellite site? Having trouble getting ICI meds to the clinic in time for the patient. So very important. When you sign up with MedMD, you will have a dedicated customer service representative, physician representative who's going to work with you very closely. Mine is Maria Canty. She's great. She's worked with me for the last 5 years, and prior to that, I've had a couple of other great ones as well. And they're very helpful. So if you're having problems with getting this logistically delivered to your clinic in time, talk to your rep, and they will help with this process. And when you go to SMS or when you go to AUA, stop by the booth and see Chelsea. She is the boss of this process and is phenomenal in ironing out issues, closing loops on stuff, making sure things get done in a timely and effective fashion. This team really wants you to succeed and really wants to help. How do you quickly establish a Doppler clinic at a satellite site? Well, how do you establish a Doppler clinic in general is not within the parameters of this seminar, but at the same time, email me, martin.s.gross@gmail.com, and I will help with this process. You come to visit me, you come to visit somebody local to you who does. I know people who do a lot of ultrasounds near you. You get this process up and running in a timely fashion. I find it's very helpful to have an ultrasonographer help with this process so that we're, tag teaming this patient. And he's, scanning and I'm taking the numbers. I have a fantastic ultrasonographer, Evan Smith, who's been with me for many, many years. And he's really great. And we have a system that works fantastically. The one drawback of that system is that we've been doing this for so long, we make the same jokes every time. The good thing is the patients are new to us, so we get a laugh every time, which is fantastic. Last but not least, any issues with ICI and anticoagulation or any other medication contraindications. Anticoagulation is tough. You really have to hold pressure on that site for a little bit. The bruising can be significant, particularly if the patients accidentally inject through a vein and they poke a hole in the vein, then that bruising is going to be pretty prominent. Holding pressure is the most important thing. But I got guys on, Plavix, and Coumadin, the whole laundry list of all these high dose or high potency antiplatelets, anticoagulants, stuff like that, and they do fine. They do fine. Just holding pressure is the key, and that's really the most important part. As far as medication contraindications, I really advise guys not to co-administer these medications with PDE5 inhibitors. That is an extremely bad idea. You're attacking the penis now from 5 different mechanisms, right? Or potentially, with all the different potential pathways of smooth muscle relaxation. Really an atrocious idea. Please don't do that, patients. And again, the most important thing I want to emphasize is when you're setting a guy up for his initial visit, check his blood pressure. If he walks in the door and his systolic is too high, his diastolic is too high, you can reschedule for a different day when he's actually taking his blood pressure meds or, sees his PCP and gets on different meds. But if you have to walk into the mystery zone of priapism without knowing the guy's blood pressure is ahead of time, you're really rolling the dice. Then you go to put the monitor on the guy because he's got a priapism, and you start, checking BPs, and you realize his blood pressure is out of control. It's not ideal. You don't have a lot of leeway to push phenylephrine consistently and aggressively. Questions answered. That's all I got.
Alrighty, we had one more question come in, so we have time for one more, it looks like, and this is about lyophilized Trimix being shipped to California. So this is going to be a Lianne question, but to my understanding, we don't ship Trimix that needs to be reconstituted, but perhaps you could speak from a broader perspective why that may be happening to this person that is asking the question.
California has a lot of different rules on beyond use dates and testing with the new 797 USP guidelines. So if the pharmacy is not able to do the testing, which we have the testing for all of our products, there are a few that don't have complete testings that we don't send to California, but it's only because of the testing and the new rules. The lyophilized is that they put the powder in the bottle and then they just ship it so that they say it's not compounded. I'm not sure those rules lyophilized with California, but all of our Trimixes are compounded, ready to go. They don't have to be reconstituted.
Or frozen.
Or frozen. We start them off frozen just to give it a longer BUD, which is 120 days. But once it leaves the pharmacy, it does not have to be. We advise the patient to put it in the refrigerator.
Ketchup.
Perfect. All righty. Well, thank you for covering those questions, both of you. We're going to go ahead.
There was one other question, and that somebody had written in it and said, "What is my favorite basketball team?" And I just want to take a moment to congratulate my Seton Hall Pirates, last year's 2 years ago NIT champions. Last year we did terrible, but Seton Hall Pirates, that's my college basketball team. Not really a big NBA fan, but that's my jam. Lianne, what's your favorite basketball team?
I'll go with my high school too then. My college team was Pitt, and they didn't do too good at basketball either. Oh, you know what? I got a favorite one, Kentucky, Morehead State, Kentucky. My son went to school there, played football, and their basketball team was pretty good. So that'd be my favorite.
Sweet.
If you'd like to learn more, we do have a couple of options for you. If you have any follow-up questions or you'd like to learn how to get started writing test doses through the MenMD provider portal, feel free to reach out directly to your account rep. They'll be happy to get you set up. And also, if you're looking for more clinical resources, please check out the For Providers page. Here we have curated expert-written articles covering the best practices for prescribing, patient adherence, treatment protocols, and building a thriving sexual health program. It's a great resource to learn from fellow clinicians and elevate your care.
If you found this video helpful and want to stay in the loop with our growing men's health community, be sure to subscribe to our channel and click the bell to be notified when new content is available. Your support makes it easier for other men like you to find these helpful resources. Thanks again for watching. We hope to see you again.